Good morning, good afternoon, good evening. I see that we have about 100 participants now, and more may join as we roll through this next 75 minutes, but we're so delighted to have you and to be in conversation with you. Thank you so much for joining from wherever you may be joining from. I'm Verena Winder. I'm the Senior Management Manager for Global Partnerships and Strategic Engagement here at FP2020. I'm here just to provide some light housekeeping remarks before we jump into our conversation. Many of you are familiar with Zoom already. We'll be in webinar mode, which means we will not be able to see any of our participants beyond our panelists and presenters. We will be endeavoring to keep our panelists' videos on. Hopefully you can see some of them now. If we are unable to do so for bandwidth issues, we'll switch to audio only later on in the program. On your screen, you should see a Q&A pod where you can submit questions. To view the presentations, the slides, and speakers' videos, look at the video panel on the right-hand side of the screen. You can select options on the top to either see the speakers in active speaker view, gallery view, strip, or gallery view grid. And to only view the presentation slides, you can select the minimize button at the top of the video panel. We will be able to see all of your comments in the chat box, so we encourage you to send your questions throughout the presentations. We'll be feeding them to our panelists during our Q&A session later on in the presentation. You'll hear more about this in just a moment, but we are also hosting our first ever Instagram Live directly after this webinar. Well, we will get to any questions we're not able to answer in the formal portion of this program. If you do experience any technical difficulties, please use the chat bot where you can send chats to all the attendees or just to the meeting hosts. In the event you're unable to reach us or need to use email, please email my colleague Yassine Bai at B as in boy, AI at familyplanning2020.org, all one word. Finally, just a note to everybody that this webinar is being recorded. And so without further ado, I'm really pleased to turn this over to Beth Schlechter, the Executive Director of FP2020, to provide an overview of today's conversations and some framing remarks. Thank you so much.
Thank you, Verena, and thank you to everybody for joining us today. On behalf of FP2020, we're truly so thrilled to be partnering with the International AIDS Society and with all of you today on this important conversation. Here at FP2020, we've been working for the last 8 years with partners around the world to support all women and girls to be able to act on a fundamental right to decide if, when, or how often they would like to become pregnant. And for us, that's how we describe rights-based family planning. It's programs that are designed to ensure that women and girls can act on their reproductive intentions. I really want to thank all of you for tuning in today, and for those of you who've worked with us every day over the past 8 years to be part of this broader global movement. As my colleague Verena just described, today's conversation will focus specifically on sexual and reproductive health integration and how and what the family planning and HIV communities can do together to further that goal. We believe, again, that every woman and girl has the right to high quality, voluntary family planning. It means access to contraceptives, information, and service. And that's regardless of a lot of things, regardless of where she lives, regardless of her income, regardless of her health status or marital status, regardless of whether she's HIV positive or not. And yet for too many women, especially young women and adolescent girls, they're simultaneously at risk for both unintended pregnancy and HIV infection. We learned some really solid data around that last year with the ECHO trial. And from that, the overriding message there is that vulnerability for young women in particular, and a real mandate from there that we must do more together to ensure that we're providing young women with that information so that they can live the life they want to lead by protecting their health status. And we know that means protecting themselves from unintended pregnancy, from a range of sexually transmitted diseases, and importantly, from HIV. So before we start this conversation today, we recognize that we're pulling together, in some ways, the people who've been working on one side or the other of HIV or family planning. But given that we all envision this world of integration together, we wanted to run a bit of a poll just to assess where everybody's thinking is, what your experience is, and what you want to get from today's conversation. So, Brina, why don't you pull that poll up? And I believe that all of you can answer the poll directly on your computer or whatever device you're using today in order to answer these questions. Do you feel you have an understanding of differentiated service delivery models for HIV treatment? Yes or no? Do you feel like you have an understanding of rights-based family planning principles and opportunities for implementation? Yes or no? And are you aware of specific opportunities for integrating rights-based family planning principles with differentiated service delivery models? That, of course, is the core of our conversation today. But you letting us know what your experience and your knowledge base are with these will really help us as we go forward as well. And then we'll hope that by the end of our time together today, many of you will be answering in your own minds, maybe I said no at the beginning, but now I can say yes. So I'll give you a moment to fill in the poll. Brina, I'll leave it to you to tell me when you think you've got enough answers there that we should go forward. Give it a few seconds. Okay, I'm just going to go forward. So we'll leave the poll up for another moment while I'm just going to continue to move us along in the webinar. So again, today our conversation was designed so that we can not only increase our community understanding of both differentiated service delivery, but also rights-based family planning, so that our communities are better prepared to actually integrate the two models. While I'll turn to our IAS colleagues in just a moment for a deeper dive into differentiated service delivery, I wanted to take a quick moment at the top to review the principles of rights-based family planning. Some of you tuned into our webinar just a few weeks ago on this very topic, and some of you are seasoned experts in this. But I'm pleased that our colleague Karen Hardy will join us later in the webinar to serve as a panelist as well. So we have some of the poll results up here, so I'm going to pause just a moment so we can reflect on these together. So do you feel like you have an understanding of DSD? Looks like roughly half the participants are yes and no, so there's a lot of opportunity here today for folks to learn together about DSD. When it comes to rights-based family planning, we have maybe a deeper understanding there, so that might indicate we have more family planning folks on the line than HIV partners, but a great opportunity to consider these together. And I can't quite see the bottom of the poll. The third question is, are you aware of specific opportunities to integrate? It looks like 27% said yes, so I'm going to guess that most folks have said no. So timely webinar, and we're really hitting a sweet spot here then of an issue that is timely, and we have an audience that wants to learn more, so we can take this together. So thanks very much. So you can go ahead and close the poll. Great, thank you. So go back to the slide that's in front of us, which are the 10 principles that we published early on in the FP2020 partnership that explain what's necessary in order to have a rights-based approach. But what's really important about these principles is what we do with them. It's how we implement them and how they're used. Because to operationalize a rights-based approach means that you consider each of these principles, which at their foundation are really what's needed to meet the needs of women and girls. And so if we use these principles as we're designing programs, as we're designing policies, as we're designing our service delivery approaches, then we have a better chance of actually meeting the needs of the woman and girl rather than meeting the needs of a program design or something that might have been funded to achieve. So by flipping that service delivery model on its head and considering the needs of a woman and girl first, we have, again, a much better chance of actually meeting those needs. And these principles can guide us toward achieving that. The same can be said for a differentiated service delivery model, DSD, a client-centered approach that adapts HIV services to meet the needs of people living with HIV and reduces burdens on the health system, will have a better outcome and will again reach operationalizing rights through a service delivery approach. So I want to thank you for tuning in, and I'm really excited now to turn this over to Anna Grimsrud for more complete introduction of DSD. So Anna, over to you. Thank you.
Great. Thank you so much, Beth. I'm just going to start my timer here. Can everybody hear me well?
Yes.
Okay, great. Thanks. So good morning, good afternoon, and good evening. So on behalf of the International AIDS Society, I want to thank you all for tuning into this webinar today, and to echo many of Beth's sentiments and also really say thank you to FP2020 for this exciting partnership. My name is Dr. Anna Grimsrud, and I've been working on differentiated service delivery for the last 10 years or so, and with the IAS for the last 5. So in the next few minutes, I'm going to provide an overview of what is differentiated service delivery, and briefly introduce how this is relevant to strengthening contraceptive care for women and girls living with HIV. Next slide. So as mentioned in that poll, a lot of you are interested in DSD and maybe don't know a lot about it. And so I'm going to take a really, starting at the beginning, kind of overview here. So in the last 10 to 15 years, we've seen a huge success in reducing morbidity and mortality among people living with HIV. And one of these successes has been the rapid and exponential scale up of access to antiretroviral therapy, or to ART. So here you can see in the year 2000, there were less than 1 million people on this life-saving treatment. And on this figure, you can see the tremendous increase in access, particularly among people living with HIV on the continent of Africa. And thanks to the involvement of communities and people living with HIV, strong activism, and international and national efforts, if you hit next, you'll see that the global goal of reaching 15 by 15 was realized. So if you hit next, you can see that we actually reached the goal ahead of schedule, and that we surpassed 15 million people on treatment before the end of 2015. And this was really a momentous occasion in the HIV response. Next slide. So in that same year, in 2015, the World Health Organization updated their guidelines and recommended that all people living with HIV, regardless of their clinical status, be started on antiretroviral therapy to both improve their outcomes, but also reduce the likelihood of ongoing transmission. And so this change in guidelines meant that everyone living with HIV, all 37 million people at the time, needed to have access to lifelong treatment. And so we all of a sudden went from being very happy about this idea that we'd hit 15 million people to realizing we needed to expand our programs to reach 37 million people worldwide. Next slide. So the question was how? Okay, how are we going to do this? How are we going to make it possible to reach 37 million people? I live in South Africa, where UNAIDS estimates that there are at least 7.5 million people living with HIV. And in some of our clinics, we have more than 10,000 people living with HIV in that cohort. So how are we going to double our treatment cohorts? And how are we going to do this if people had to come to health facilities every month, often wait for hours, just to collect their HIV treatment refill, when in fact, many of them were clinically stable and doing very well? Next slide. And so this term, differentiated service delivery, was born. DSD was founded on the realization that this one-size-fits-all approach was not going to be sufficient to get us to reach everyone living with HIV with treatment. And HIV service delivery had been innovating for years and changing and evolving, and continued to do so. There were a large number of health facilities now offering treatment. We had nurses that were able to just prescribe, and we had strong treatment supporters and peer providers ensuring that people could access care closer to home. And we needed to realize that people living with HIV were at the center and were going to be key to providing their own self-management to a large extent. So DSD is client-centered and seeks to simplify and adapt services across the care cascade, both to reach the needs of people living with HIV, but also reduce unnecessary burdens on the healthcare system. Next slide. So differentiated service delivery applies across the HIV care cascade. So there's differentiated prevention, differentiated testing, but today we're really going to focus on differentiated service delivery for HIV treatment. So next slide. As I've said, differentiated service delivery puts the person living with HIV at the center and considers their clinical needs, what specific populations they're a part of, and the context in which they live. And then we can adapt the services both to their needs with a public health approach by adapting these building blocks. So we can change when, how often they receive services, where those services are provided, their location, who is providing them, be they clinically trained people, peers, or community healthcare workers, and what is included in their package of service delivery. So by adjusting these, we've come up with 4 different DSD models for HIV treatment. And I'll walk you through those on the next slide. So these are the 4 DSD models, and I'm going to discuss each briefly. First, on the top here, you can see that there are group models, and these are when people living with HIV receive their HIV treatment as part of a group. And these groups can meet in health facilities or they can meet in communities. Next. The first example is an ART adherence club, and this generally involves a group of clinically stable clients who meet between 2 and 5 times a year to get their ART refill and receive adherence support from a lay provider. Next, you can see community ART groups, which are often slightly smaller, between 6 and 15 people, and they all generally live in the same area. And in a community ART group, this is led by the clients themselves, and they take turn rotating who goes to the facility to collect the refills that are then distributed in the community meeting place to the whole group. Next, we also have individual models, such as those that happen at a health facility. So in a health facility individual model, someone would be fast-tracked to receive their ART collection, either from a specific room or by going directly to the pharmacy and not stopping for other checkpoints along the way within the facility. And then finally, next, you have out-of-facility individual models where people get their treatment closer to home, maybe through mobile outreach, maybe through a community pharmacy or a private pharmacy partner, maybe through a locker, or maybe even by being delivered to their home. Next slide. So these models are happening around the world, and this is just an example from Zimbabwe of one of those community ART groups, or in this instance, it's called a CARG. And here in Zimbabwe, a group of around 15 people is part of a CARG. They get 3-month refills that are collected from one member and distributed in their community. And then they go to the facility just once a year for their clinical visit and for their rescripting and for all their clinical needs. Psychosocial support is given in the group, and they obviously have access to the health facility at any other time if they need it. So this sort of model fosters a peer support structure and then helps people address lifelong therapy and other issues such as stigma. So next, the question is, how can we leverage this? And if women and girls are in these models, how can we make sure they have access to quality contraceptive care and that they don't have to go to the facility all the time if they don't need to for their HIV? So in my final slides here, you'll see that 15 years ago, HIV care was super medicalized. The drugs were very expensive and had a lot of side effects, and people had to see clinicians at hospitals frequently. Next, you'll see that today, many people living with HIV are involved in the self-management of their disease. They only see a clinician every 6 or 12 months, and much of their care and their ART happens close to home with visits to health facilities only once or twice a year. So finally, we can see that DSD is not just for HIV, it's about client-centered care. And the first time I saw a DSD model was actually in rural South Africa, where people with diabetes were meeting as part of a support group. So we're now somewhat in this transition, going from 1.0 to 2.0, where we need to acknowledge the health needs of people and all of the health needs that they have. People living with HIV are not defined by their HIV, and they may have other health needs, preventative health needs, or other comorbidities. So finally, next, we have a lot more we could share around differentiated service delivery, so we invite you to visit differentiatedservicedelivery.org. And next, I'm going to turn over to my colleague, Chelsea Maroney, who's going to talk a little bit more about the opportunities for integration and leveraging DSD for family planning care. Thanks very much.
Good morning, good evening, and good afternoon. Thanks very much for joining. The importance to access to contraception for women and girls for reasons of health and rights is well established, and an integrated approach to HIV and sexual and reproductive health care has been long promoted as the cornerstone of the HIV response and is recommended by the WHO. But the progress in really effectively joining and co-delivering HIV and family planning care has been insufficient to date, I think, as most of us would agree. One indicator that underscores that we are not yet where we really should be, where we would want to be in this regard, is the measure of unmet need for family planning. Next slide, please. So there is tremendous progress being made around the world, much of it to the credit of Family Planning 2020, but the unmet need for family planning among women and girls living with HIV remains high, with over half of the 1.5 million annual pregnancies in this group unintended. Next slide, please. And the highest unmet need for family planning among women living with HIV is often amongst the most vulnerable. So for example, from a range of settings, you can see here that it's among girls and young women, women and girls who are postpartum, and key populations. Next slide, please. So at IAS, we have been mapping out contraceptive unmet need, contraceptive method mix, and reviewing HIV and family planning policies and guidelines across countries that are implementing DSD models for ART. And this is to begin a process of identifying gaps and, more importantly, opportunities for doing things differently and doing things better. I'm not going to take you through the details of this slide, but what we generally see is high levels of unmet need, low uptake of the long-acting reversible contraceptive methods, the IUD and the implant, with a predominance of the provider-administered injectable contraceptive, suggesting somewhat limited method choice in many settings. I think it's really important to note here that met family planning need does not necessarily equate to rights-based quality family planning care being implemented. So high quality, effective family planning care is not simply about getting someone onto a method of family planning, but about ensuring that it is the right method for that girl or woman at the right time, with the information and method provision delivered to her in an acceptable way and at a location that meets her needs and preferences, grounded in a rights-based framework. And we are hoping that linking family planning care to DSD models of HIV care may go a long way to achieving this. Next slide, please. So to help in positively moving this area forward, the International AIDS Society has developed a short supplement on how DSD might be an opportunity to strengthen family planning provision for women and girls living with HIV. The supplement, which has been designed for use by a wide range of groups, international, national and district managers, implementing partners, community partners, and donors, basically provides key principles for family planning in the context of DSD, guidance on how family planning can be integrated into different DSD models, and some really encouraging case studies and examples of how this is currently happening in different settings. Next slide, please. So differentiated ART delivery models can and should be leveraged to strengthen family planning care. And there are components of this that can happen throughout the DSD pathway, at entry into differentiated ART delivery models and during follow-up. At referral or start in a differentiated ART delivery model, a quality family planning consultation should be offered, with both informed choice through counseling and the offering of contraceptive commodities. And given that most ART DSD models involve reducing the frequency of clinical consultations and health facility visits, there should be a careful conversation about what options, what contraceptive options and what methods might best align with the client's needs and preferences going forward. This discussion should be had and documented in an ongoing way at each follow-up and clinical interaction. And at ART refills, clients should have the option to receive their contraceptive care with their ART. Next slide, please. In the same way that we use the DSD building blocks to build a model for ART delivery as just presented by Anna, we can use these building blocks to think about building a model of family planning care within DSD models. With the client at the center, we can carefully consider the when, ideally linked to HIV care, the where, ideally ART and family planning should be provided in the same location, the who, ideally by the same healthcare provider where appropriate, and the what. Next slide, please. So this very busy slide is an example of the DSD building blocks description for a community ART group model in Kenya. The women in this community ART group raised the point that they had to go separately for their visits for family planning and ART. And this is now changed in a very positive way. So those who need contraceptive visits are now the ones from the community group nominated to attend the health facilities. Contraceptive and ART resupply durations are now realigned in this setting, and further adaptations are being explored, such as the prepackaging of oral contraceptive pills and the community delivery of the self-administered injectable. So this successful example shows that women are now able to access a range of contraceptive methods within this DSD model. We haven't indicated condoms and emergency contraception here, but they're also important methods to include. And they're able to access these at all points in the DSD pathway. But it also highlights some gaps and challenges. So there is a recognition in this setting that the vast majority of women here are using the shorter acting and potentially less effective methods, and that a focus on high quality counseling for the long acting reversible methods, as well as expanding access to the LARC options, may be important going forward. Next slide, please. So, using a rights-based, client-centered approach, all women and girls living with HIV in differentiated ART delivery models should be offered family planning, counseling, and information in an ongoing way, with a choice from the full range of contraceptive methods and easy access to the methods of their choice. HIV and family planning policies, programs, and services should be aligned in order to enable this. And we've identified 5 key principles that we believe may be important to achieving this. Firstly, engage people living with HIV, the recipients of care, in the design and implementation of these models. Secondly, utilize the DSD referral and follow-up as an opportunity for the continuity of high-quality family planning care. Thirdly, within a rights-based framework and in the context of informed choice, positively promote long-acting reversible contraceptives in DSD models as an option for women. Fourthly, align family planning and ART resupplies. And finally, integrate family planning and ART care in DSD models, not only at the facility, but also in the community. Next slide, please. So leveraging differentiated ART delivery models presents an opportunity to increase the coverage and also improve the quality of family planning care. Advocacy for this to happen must address investment in and access to the commodities, along with national policies that overcome barriers related to how family planning care can be delivered in the context of HIV care. We are in a moment of renewed momentum around family planning and contraceptive care for people living with HIV. I think everyone would agree with that. And the question is, can we, or perhaps more importantly, how can we capitalize on this moment to push for policy and implementation coordination for collaborative planning and funding that enable real advances, sustainable advances in family planning care for women and girls living with HIV? Thank you. Apologies for the rush on that, but I recognize that we're running behind due to technical difficulties. So now I would like to hand over to my colleague from the International AIDS Society, Dr. Helen Bygrave, who will be moderating our panel discussion on DSD and rights-based family planning, making this work in the real world. And she will also be moderating the audience Q&A session to follow. Hopefully we'll have some time for that. Helen is a UK trained physician and has been working with international HIV and TB programming since 2005 with MSF and with the IAS DSD initiative for the last 5 years, supporting the development of international and national guidance on DSD. So we're in good hands. Over to you, Helen. Thank you.
Brilliant. Thanks, Chelsea. So hello, everybody. I've got 5 great panelists who I'm going to introduce, but I also want to really encourage you to be using the Q&A function, which you'll find along the bottom tab of your Zoom screen. Please pop your questions in there. If you can say kind of who you are, and if it's directed to one particular panelist, do that as well. And we'll be keeping an eye on that. Hopefully we'll have a little bit of time to address some of your questions as well. If all the panelists want to pop their videos on, I'm going to quickly introduce you all, if that's okay, and then we'll dig into the questions. So we have, first of all, Karen Hardy, who's a senior fellow at the What Works Association. Karen was previously director of the Evidence Project at Population Council, and she's been a long-time partner and consultant working with FP2020 and is a social demographer by training. So welcome, Karen. We also have Wame Jallow. She's the Director of Global Programs and Advocacy at the International Treatment Preparedness Coalition, based in Botswana, alongside Chelsea there. And Wame currently manages all of ITPC's programmatic and strategic pillars, and has worked within civil society and development partnership sector for over 18 years. So huge amount of experience. Welcome to Dr. Lazarus Monmani, who is the technical advisor for HIV differentiated service delivery in the Kenya National AIDS and SDI Control Programme. So he will bring the Ministry of Health coordination perspective. And Dr. Monmani has 10 years of experience of delivering various service delivery roles in a number of PEPFAR programs. Next, we have Tabitha Yekwa, who's a nurse working for Medicine Sans Frontières in Kailicha in the Western Cape in South Africa. And Tabitha is responsible for running and supporting the postnatal clubs, and she's going to tell us all about what they are. And last but not least, and I actually just want to say, unfortunately, a colleague, Afilele Gumede, who's a youth activist in South Africa, unfortunately has fallen ill. We give her our best wishes. And very kindly, Lillian Benjamin Mkwayozi from Tanzania has stepped in. Lillian is an adolescent girls and young women's technical advisor with AVAC's Compass Network. So welcome to all the panel. So I'm going to start off with a question to Wame, if that's okay. Wame, the word integrated gets used a lot, both I think from the family planning community and the HIV community. So in your mind and in your experience, is integrated contraceptive ART care, what does integrated mean to you when we talk about contraception care and ART? And what might the barriers be, particularly when we think about delivering that in the context of differentiated service delivery? So over to you, Wame.
All right. Thank you very much, Helen, for the introduction and also for the question. I really appreciate the past presentations that were made, very powerful presentations, and really set the context, I think, to this panel. I think maybe if I can start by defining it the other way around. You know, at the end of the day, we need to be looking at who is the recipient of care and what is the definition of the recipient of care. And for us as ITPC, we really believe that, you know, this is a whole person. A person walks into a health facility and has many different varied needs. And as a result of that, you really need to make sure that the policies, the services that are offered are able to meet the needs of the individual in their entirety, right? So the integration part of that really is important because it then meets that definition of the whole person. And I love what Dr. Anna had said earlier, where she said, you know, about, you know, how do we ensure that, you know, the health system, the health policies meet the needs of the individual. And that integration has an opportunity to do that if we actually understand the definition of who and what the whole person actually looks like. So recognizing that, I mean, I think it's a no-brainer that integration is important. And we see those challenges, particularly when we look at, I mean, before COVID, there were multiple health access issues. We can speak for hours about that. But COVID has really brought to light, and not just my understanding, but every person's understanding of what health access issues actually look like. I can now speak to my friends and say, hey guys, you know, these are the health access issues. And they say, I understand because of COVID. So how can we take advantage of that? How can we really make sure that everybody understands what the definition of health access, how we can have an integrated approach, how we can meet the needs. And from an SRH point of view, and that's a silent conversation that that not many people engage in. So just sort of taking a step back, we've actually done a bit of analysis as ITPC with some other partners like Salamander Trust and Making Waves, to really understand what are the problems, why are we here, why are we having these conversations that many of us think are a no-brainer, but unfortunately we do need to have these conversations. There has been limited access to SRH and particularly HIV services for women and young girls. You know, the COVID response has really demonstrated that our response as a whole is really not integrated, but there are also a lot of gender inequities, which ultimately increase the burden of healthcare system. Women and young girls are faced with many challenges, and this is just a recipient of care as well issue, like inability to access viral load testing, how people actually access services is important. So if I have to travel 5 kilometers to a healthcare facility versus 100 kilometers to deal with issues of stigma, or I know that there's a doctor that has a facility versus another. Those are things that are very important to an individual, particularly to women. We hear a lot from women issues around informed choice. So, and that's really important because the people are really taking more proactive choices around choice to health and what services they would like to access. And I really love what Dr. Chelsea was saying earlier, to say there's a wide gamut of SRA services and commodities, but what is actually available in countries? And we hear issues in many countries around stockouts, you know, the unavailability. So even if you want something, even if you walk into a health facility and say, I know I'm supposed to get X, that commodity is not always available. And it's not about a one-hit wonder. I can't walk into a health facility today and have it and then come back the next month and it's not available. It doesn't help with ensuring continued access, retention into service. And at the end of the day, it's about quality of service. If I walk in today and I don't get what I need, I'm not going to come back tomorrow. And that's what we need to also remember, that we're trying to ensure that we're capturing people into the healthcare facility and system. Saying all of that, and there are many other issues that I can highlight, but I think in the interest of time, it's a no-brainer. And we hear from women all the time that integrated service delivery is really essential. But I think, as Dr. Anna was saying very clearly, there are different ways, people have different needs. People have different ways of wanting to access service. And this is where differentiated service delivery is really important. And the more we empower women living with HIV and vulnerable to HIV in terms of these are the different types of services and commodities that you can have access to, through treatment education, training, through knowledge building, the more we can actually build and generate demand for those services. But people are not always going to want to get it at the health facility. And that's the reality. There are many challenges to getting to the health facility. There's a cost of getting there in terms of money. There's a cost of getting there in terms of time. Women have many needs. You're taking care of children, you're running to work. You know, there are many other social aspects of it that we need to consider. And in that, we need to realize that people's needs are quite vast. And differentiated service delivery offers an opportunity for us to say, okay, if you can't get it at a health facility, how else can we bring the service to the community? How else can you ensure that somebody gets the same type of level of service, especially as Dr. Anna was saying, if you're a stable patient, you don't need to come into the health facility. So why are we forcing people to go to a place instead of bringing the service to them? So I think to answer your second part of your question, Dr. Helen, it is a no-brainer that differentiation service delivery is important, and we do need to do that. And I really love the supplement that IAS has developed that really has some very strong points around, you know, making sure that DSD is rights-based, it's, you know, client-centered. It is really looking at what are the different, understanding the needs of different women and young girls and women, and making sure that the different models as presented by Dr. Anna are available. So whether you're doing community advocacy groups, or whether you're doing facility-based services, or fast-tracked in a fast-track way, both of them meets the needs of that. And we hear that from women all the time. I want to be able to peer together with women who have my same circumstance, and maybe I can send someone to get my ART because I can't, or get my contraceptives because I can't, because I'm taking care of children, I'm running to work, I'm doing all these other parts. So making sure that the models meet the needs of communities from an informed point of view is important. Disadvantage, I mean, I don't know if we know that yet. I think we need to try out a different way of service delivery before we can actually say that disadvantages. But in a broad sense, we know that stigma and discrimination, obviously for HIV response at least, has been a big treatment access barrier. So as we think about DSD, is there any way that we can ensure that issues of stigma are actually diminished as we roll out services into the community? So that's all I have to say. Thank you.
Brilliant, Wame, thank you. And I think, you know, we've always said that differentiated service delivery is about having the client, the recipient of care, the woman living with HIV at the centre. There's an interesting question about self-managed methods of contraception and how that might also facilitate this in the context of less frequent visits in the DSD. So I think that's also an important point. Thank you for that question to think when we're designing our models. Tabitha, I hope you're there. We can't see you on the video, but I hope you're there. I just want to turn this over to you because there's quite a few questions coming in about kind of how these models actually might work, and you've got experience of actually running one of these models. So can you tell us a little bit about the postpartum clubs you run in Kailicha in South Africa? Really just to tell us the nitty-gritty of how you make that work and how contraceptive care is provided alongside the HIV services that those women need. You just need to unmute yourself, Tabitha. You're on mute. That's it.
Okay, sorry. Thank you, Helen, and good morning, afternoon, and evening to everybody. Yeah, so PNC is an HIV model of care that is designed for HIV positive postpartum women and their HIV exposed babies. Because retention in care is known to be quite low during the postpartum period, the aim of PNC is to improve the mother-infant pairs retention in care, and also to improve other outcomes such as the viral load suppression, the infant testing, and also immunization, the uptake. The postnatal club is made up of the group is made up of a minimum of 3 mothers and 3 babies. That's 3 mother-infant pairs, and a maximum of 15 mother-infant pairs. And there is one nurse that is allocated to PNC, one nurse and 1 facilitator. They run a PNC club. And we have a PNC, the model of PNC is made up of 4 components, which are namely the ART adherence model, where like patients who are HIV positive meet in a group and they receive their refills and their HIV care. So it's happening in a group model. And we also have some ECD activities that take place during PNC. And we have the one-stop shop, what we call a one-stop shop. That means that all the care of the mothers and infants is being delivered at the one station in a one visit at the same facility. And then there is an integration of the mother and the baby's care. So in the postnatal club, the care of the mother, that's both HIV and non-HIV care of the mother, and that of the baby is being taken care of on the same day and on the same visit. And the PNC visits, they are aligned to the baby's immunization schedule. like starting from 6 weeks, and then it's 10 weeks and 14 weeks. And then from 14 weeks, then it follows up a 3-monthly schedule up until they are 18 months. And the mother infant exit PNC at the age of 18 months. What else? During the PNC, we run some information sessions, which are run from 30 to 45 minutes, where we discuss different topics that are HIV related or non-HIV related. And in those group discussions, we also discuss family planning in detail, and then give the mothers the opportunity to make an informed decision when it comes to the family planning of their choice. And yeah, I think that's basically it. I'm not sure if there's something that I've left out you want to know more of in PNC.
Just one question, Tabitha. Just what I'd just like to hear is, for those women who choose to use oral contraception, or for example, injectable contraception, does that align with their ART refill? Is that clear in your model?
Yes, certainly. So what we advocate for is the long-acting contraception, like the IUDs and the implanon. But for those that opt for injectables and oral contraceptives, we align them with the visit, which is usually 3-monthly. So they always get a refill, or they always get their family planning at the day of the postnatal club.
Fantastic. Thank you. Thanks for sharing that experience, a kind of like on the ground experience, Tabitha. So Karen, if I can come to you, kind of we've heard the kind of those basic principles of differentiated service delivery from Anna, and from Chelsea how we're thinking about incorporating the contraceptive care. But how do you see these principles being used when thinking about models of rights-based family planning, and where can you see the overlap or maybe the divergence in these approaches? Yeah.
Thank you. I've really appreciated the comments of other panelists and also the presentations today. You know, finding ways to make sure that anybody who wants to use family planning, including women with HIV, that they can do so in the most convenient way possible is you know, such a goal of rights-based family planning, and I can see is included in the various modalities of DSD. And we in family planning have a long history of community-based programming with you know, community-based workers providing methods and referring for others. So a question that I have is, can DSD be sort of expanded and better linked with, you know, what we're already doing in community-based family planning? We also have a bedrock principle of full, free, and informed choice, with a range of methods, full information, and agency to choose. So the model of rights-based family planning has to be that clients choose. So I'm listening to everybody talk about, I like the term positive promotion of LARCs, but that's just something we really have to think about, because we might think we're promoting methods positively, but clients don't necessarily hear that. They hear, I'm being pressured. They want me to use an IUD. They want me to use some other method. So I think that's the one area of DSD that I think we need to be just really careful in how we message it. And I've been I've appreciated hearing how it's been talked about, you know, on this webinar today. I think the idea of one-stop shopping and having services together is also a great principle of rights-based programming. It's harder it's easier in theory than in practice. Funding streams tend to be siloed, et cetera. So I think as long as that can actually be worked out, that's great. So I'm gonna stop here because I know we have other people to hear from. But thanks so much.
Thank you, Karen, because I think that's why, in a way, that's the purpose of today, in a way, is bringing your perspectives from family planning. And I think, you know, exactly as you said, it's about promoting choice and making sure all those methods are explained and put to the women as options, and that we're not kind of inadvertently directing in one way or the other. Yeah. So, Dr. Mugnani, we want to hear from you now from a national program perspective, what your experience is in terms of how can we bring together the sexual and reproductive health programs at national level with the ART programs to make this actually happen on the ground. We've heard, you know, some examples from South Africa. I mean, I think in Kenya, there's some great work going on. But as you scale up, what we've seen over the last few years is these models for ART delivery have been scaled up. How can we really make this happen at scale to make sure that women in those models have access to integrated contraceptive care? Over to you, Dr. Mamanyani.
Thank you, Helen, and thank you everyone for the great conversations that you've had. And yes, you're right. I think one of the questions we always ask ourselves is how can we be able to provide what we are calling the one-stop shop services for our women, so they're able to access family planning services as well as ART in the same environment without having to come for extra visits or without having to move to the next clinic or so. And one of the approaches that we've used definitely in Kenya is the issue of integration of family planning services or as sexual reproductive health services within the HIV clinics, or what we call the comprehensive care centers in Kenya. And one of the things that we have to do is to have continuous training of healthcare workers so that they're able to provide, for example, the long-acting methods, the implants, and so on. They're able to provide this. We had to do simple things like just putting a cabinet within the HIV clinic and putting some SOPs and the continuous training. And one of the other things also that we've done is the issue of aligning clinic visits for the family planning for the women coming to the HIV clinic, so they don't have to come for any extra visits. And for those, it's been a challenge, especially for the DSD models. We know that for the facility-based models, like the fast track and the facility groups, it's easier to integrate these services. But for the community ART groups, it's been a challenge. And one of the things, as you saw from the earlier presentation, is that for oral methods, then they're able to be picked from the facility and taken to the community for the patient, or for the women. But for the injectables and the long-acting methods, then we have had to look at, for example, for the healthcare provider-led models, where the healthcare provider is the one who is going to the community, and therefore they're able to provide this within the community as they provide the ART services. But this is now only limited to the healthcare provider models. The other thing that we've done within the facility is definitely the rollout of what we call continuous pregnancy intention screening. And for Kenya, we have a tool that we call the pregnancy intention assessment and family planning screening tool. And this tool is administered on a 3-monthly basis for all women of reproductive age coming to the facility and or the HIV clinic. And from this, we are actually able to categorize women into 2 broad categories. Those who desire to be pregnant, they are started on what we call preconception care, which we have clearly described in our guidelines. And we are able to counsel their partners about issues about being virally suppressed and issues of adherence. And for the negative partners, we are able to start them on pre-exposure prophylaxis. For those who wish to postpone pregnancy, then we are able to counsel them on the available methods for family planning, and they're able to make a choice. So I think, just probably to summarize what I've said, is just integration of SRH within the clinics and also within some of the models where it's feasible, aligning clinic visits, continuous capacity building of the healthcare workers, and really mobilizing and using as much of the available resources as much as possible. And of course, always putting the woman at the center in terms of their preference for family planning method. Thank you.
Thank you. I mean, I think that's really helpful. And I think what's really important is, say a lot of what's documented has been kind of small pilot studies, but that's really fantastic to hear in terms of kind of from your perspective at national level, how that you have seen it possible to take it more to scale, Dr. Mamanyani. So I'm sure there'll be lots of people with questions in terms of those practical steps that you took. And I think I've got another question for you maybe at the end if we have time about the policy issues around that. So lastly, but definitely not least, and I want to actually kind of come to you, Lillian, at the end, to kind of take this full circle from what Wame started with in terms of perspectives of you know, the users and getting this right for you. in your experience, Lillian, and also your peers and the young people, adolescents and young women that you work with, what's really your real life experience of receiving contraceptive care, and for the models of ART delivery in Tanzania that you experience and you have access to, what do you see going on in terms of that contraception being made available in those models in your experience there in Tanzania? So over to you, Lillian.
Thank you so much, Helen. Just making sure that you can hear me.
Very good.
Hello, everyone. So this is Dr. Lillian Benjamin Mwakiosi from the United Republic of Tanzania. And without really wasting time, I'd like to go direct to the question that Helen has asked. Maybe I would start by sharing a bit of my experience when it comes to accessing contraception at an individual level. The biggest issue I've been facing, and also from my peers seeing around, has been the stigma and discrimination associated with access to family planning methods. And this is majorly contributed by how conservative our communities are. And ideally, as a young person, you're not expected to be sexually active. And there's always that struggle when you go to the clinic to access services, because there's always those now parental healthcare providers who'll be like, you're too young for this. Maybe you shouldn't use this method, you should go for this. And for me, that has been a barrier ever since I do not have much background when it comes to contraception and medicine generally. And I feel like it has affected me up to this minute, that with all the knowledge, I still feel like I am limited. And the most method that I would run to are condoms, and rarely would be emergency pills, for instance. So I think it's really necessary to look at how these services are being provided. You may have the information, but still not be able to access services because you feel like there's something that is blocking you from doing so, and that should not be the case. And when it comes to the ART models currently in Tanzania targeting adolescents and youth, we have peer support clubs that have been a great manifestation of differentiated service delivery. And for instance, for peer support clubs that we have at the moment, we have young people who meet on a timely basis to share different educational materials. And it's not necessarily HIV or treatment related. Sometimes it can go out of that circle, but also there's sports activities involved, there's arts and, involved, but also experience sharing when it comes to other life issues like, economy and whatnot. But also I would really want to insist that within these peer support clubs, there's that follow-up element among peers, that this is where the peer support or peers who would do home care follow-up come from sometimes. So there's that system within young people that they can actually support each other to make sure that they stay on treatment. And there's also a way that our system has gone an extra mile to extend the way that services are being delivered. And one of them is making sure that there are special days that young people can actually access ART. There are those who actually dedicate extended hours after work to accommodate those young people who are in school during weekdays. But also there's something that I really have discovered recently. There's also a specific package for young mothers where usually after RCH clinics, they do get get together and share like experiences and knowledge, and making sure that they have all the basics when it comes to taking care of themselves, but also protecting their babies. For weekend hours, usually for young people, special days for clinics are Fridays. In most clinics are Fridays and Saturdays. But I really have to be clear that this is not the real picture in every other clinic here. So it's something that needs to be scaled up, because especially if it shows that it's working better in terms of adherence to young people. And in terms of integrating now these peer support clubs with family planning, I'm really not sure on that end or how accessible these contraceptive services are to young people living with HIV, for instance. So maybe it's necessary to also, the fact that people do not really know, again, could be an issue. Maybe there's not much being done, but also coverage is an issue. There could be a few best examples in certain advanced clinics, but the situation might not be the same when you go to now the rural areas and out of town. And lastly, maybe my call to everyone when it comes, I think it's really necessary to integrate contraception into CTC, but also generally prevention and care services. Because as a young person, you don't want to be moving from one wing to get contraceptives, and then you have to go to another wing to access care and treatment. It's really necessary to come around now the examples that the panelists, my fellow panelists have shared, like one-stop shops, having the multi-month scripting, which is currently also available in Tanzania, but it has to be scaled up as well. But also we need to look around how else can we get to deliver services according to the needs of these young people and with a wide range of choices as well. Thank you so much.
Lillian, thank you. And thanks for that call at the end. Yeah, I'm going to take the liberty, and I realize we're probably running slightly late because of the tech problems, but I'm just going to take a liberty just to pick a couple of points coming in from the Q&A. And thanks to all of you for the questions. I think there's some written answers coming in, so do check those written answers in the Q&A box. I'm going to put this to Dr. Momnyani first, but then if other panelists want to chip in, just a question. What's a practical first step that countries could adopt to have better integrated SRH and HIV services, particularly during COVID, with the opportunities maybe that presents? And what did you have to do at policy level to make this work? If you could give us some thoughts on that, and I say if others want to chip in after Dr. Momnyani, let me know.
All right. I could start with the second one. I think at policy level, definitely our guidelines that we developed, the PMTCT guidelines, recognize family planning as the second prong. And we have put in place very elaborate procedures on how integration should happen. At the national level, we also do have, we have set in place a technical working group for MNCH, which has both our colleagues from the HIV program and from the SRH program. And in that community of practice, the community of experts or the technical working group, we also do have recipients of care who sit there. So we are able to, on a quarterly basis, to really engage and be able to get ideas which we are able to build into the programs. I think on the second, on the first question, I think it's just the continuous engagement with the recipients of care, these women, and just knowing what they do prefer. And even as we design some of the services, really taking into account there are some of the preferences and what they would like us to be part of the services, and just that continuous engagement. I think that's really what is key. Thank you.
Thank you. I don't know if anybody has any other comments on that. I'm just going to have one last question. I don't know, Karen, from your experience from the contraceptive care world, one of the points somebody's made is that when we're delivering our DSD ART services, often some of that is done by lay workers or expert clients. And our policies have allowed that. In some instances, they're distributing those medicines, maybe they're pre-packed, but lay workers are actually distributing the medicines. And I don't know, maybe if you can have a comment around how task shifting could work for the contraception commodities as well, so that we can align them and it be done potentially by lay worker. I would say maybe Wame also has a thought on that, but Karen, over to you if you don't mind.
Oh, thank you. And I was just listening to Lazarus talk about policy issues. Talk about a policy issue. We've spent years trying to get community health workers to be able to provide injectables. So this is a really a serious question about task shifting to lay workers. There's just going to have to be a lot of sort of showing that it can work and sort of implementation science on that. I think self-care and self-injection is a really, I saw somebody in in the chat asked about self-care. And I think particularly in this time of COVID, I think that's a real opportunity to move to really look at self-care options. But I hope another panelist has a more positive answer than I do about the lay workers being able to provide contraceptives. So I'll turn it over to somebody else who hopefully can respond also. Great question.
Wame, do you want to have the last word before I wrap up the panel?
Yes, that. No, I totally agree. I mean, at this point, it's all hands on deck. I don't think we have a choice. I mean, I think at this point in time, if we really want to offer services that matter and make sense to people and meet their needs, we really need to think about capacity building in a different way, service delivery in a different way, ensuring that there are policies that protect individuals who are providing the service as well. And that's something really important for countries to consider in terms of the Public Health Act. We hear in many countries, they're saying, you know, they still have the very old 1980s rules of, you know, a doctor and a nurse can provide services. Not anymore. You know, how do we, the NGO sector started off, and community sector started off by lay people coming and what they call the third sector of the economy, coming in and supporting where governments couldn't, where development partners couldn't. So I think we need to think very differently, and we need to ensure that the policies and services really facilitate that. And communities need to also feel protected. If I do this, what is my you know, what are my guarantees that, you know, no one will come back tomorrow and put a, you know, handcuffs around my wrist for something that I've done. So yeah, I think we need to think differently. DSD is definitely the way forward, and how we do that, I think, is through capacity building and informing communities in terms of empowering communities on informed choice. If I know what I need to demand for, I am going to make sure I go into the health facility and ask for that service, and ensure that the quality of the services provided meets my needs.
Brilliant. Okay, so I think I'm going to wrap up, and a big thanks to all of you and to everybody listening. I think there's lots of food for thought. I think there are policy issues to address, but ultimately we need to make sure we're designing these differentiated service delivery models in line with what the recipients of care want, and make sure we have that at the core of what we do. So thanks to you all. I'm just going to hand over now to Beth Schlatter, who started the webinar, just to do some final words, and I think actually repeat the poll to see how you all feel about differentiated service delivery and how it can help contraceptive care. So over to you, Beth.
Thanks very much, Helen, and thank you so much to all of our panelists. As we saw from your remarks and the questions that were really live in the Q&A, there's a lot of interest in this model, a deep need to learn from one another and to build that evidence base, so that we can compel programs and policies to move together more effectively to meet the needs for women and girls. So let's go ahead and put that poll back up and just see if we landed somewhere a little differently than where we started as a group on this call today. I think the poll's coming back up. But I want to note as well that you know, for FP 2020, we're in the process of transition. Because of COVID, it's going to take us longer than we had originally envisioned, but it does give us a chance to do things like what we're talking about today, to deeply consider how the next iteration of our partnership ensures that we're learning from the first iteration and from the kinds of relationships that we're building on that existed before FP 2020 came along, but how this partnership offers us an opportunity to take steps forward through partnership. And conversations like this today really help us all better understand the need in the sector, but also how we can work together and how we can define that for ourselves through partnerships. So again, the questions are up for us. The first around, do you feel like you now understand differentiated service delivery models for HIV? Do you feel like you have an understanding of rights-based family planning? And are you now aware of specific opportunities for integrating rights-based family planning into differentiated service delivery models? I think we still have a long way to go on that. There were a lot of studies and a lot of information that was mentioned today. So we will be making all of this available on the FP2020 website. Please also do go back and scroll through the chat because Chelsea and other colleagues made studies available, links to the studies in the chat, so you can have those links right now. So we don't have to wait for us to make sure everything's on our website. But please do continue to reach out and let us know what more information we can make available to you. And if you have ideas for these kinds of conversations that would be meaningful and helpful to our sector, that we can use the FP 2020 platform to help bring folks together, to answer questions, to share information, to share research, and to create opportunities for conversation and from learning from one another. So the panel, or the poll has probably been up long enough. Let's go ahead and see if we can share some results up here now. So great. I think we got a lot of yeses across the board, which is a great confirmation that we have a good starting point here from colleagues who've made the time today. So please do help spread the word that this panel or this webinar will be available in a taped version. We'll be shooting it out through all of our social media platforms as well, but there's so much good and rich information here. And I believe it's really encouraging to know how even during this time of pandemic, when there are these gaps between all of us physically being together, that we can use the tools and the resources at our that are available to us to continue learning from each other, to continue to build community around healthcare and the issues that we're all working on, and to support one another in our work and in our efforts. So thank you again for your time today. We really do appreciate it. Please be in touch with us, and we'll do our best to continue to use this platform in ways that we hope are useful to you. So many thanks to all of our panelists for being here with us today. Many thanks to IAS and Anna and Helen for your partnership. And I want to give a special thanks to Chelsea. We met last year during one of the ECHO trial meetings in Zambia, and from there started this idea of how we might work together. So I want to thank her both for her flexibility today and jumping in when the video didn't work, but also for inspiring us with ideas for how we can all work together for the greater good of the women and girls that we all seek to serve. So thank you again for your time. Stay healthy, stay in touch, and all the best. Thanks and goodbye.